And that's what caught the attention, and that's when toxic shock syndrome actually came into picture, after which these highly absorbent tampons were banned and the incidence gradually reduced. As of now, the streptococcal infection, that is the invasive group A streptococcal infection, which causes toxic shock syndrome, is almost as high as 3.5 per 1 lakh persons, with a very high case fatality rate. And if you look at the Indian literature, the largest study cohort that I could find was that from PGI Chandigarh, which was a 10-year study in which hardly 63 cases of toxic shock syndrome of staph and strep based on the diagnostic criteria as per CDC were defined. And this is a very small number of patients. This is a very sparse data. Hence, how common is it or how uncommon it is, we are not clear. But definitely there must be some underreporting, and there might be some underdiagnosis of this event, maybe misinterpreted as either gram-negative septicemia and PCOS. Hence, my attempt will be that we are more prompt in identifying and more aggressive in managing a toxic shock syndrome, as it has very high mortality. So what are the risk factors? The risk factors vary from simple skin cuts and injuries and burns to use of tampons, as we described, and non-menstrual staph is essentially because of surgical wounds, postpartum infections, sinusitis, osteomyelitis, arthritis, large area burns, even enterocolitis. Streptococcal toxic shock syndrome, however, is more towards skin and soft tissue wounds. So, if we were to classify, if we talk about toxic shock syndrome caused by group A streptococcal, that is mostly strep pyogenes, pardon me for this error of streptococcal pneumonia. So, this would essentially be because of any kind of pyogenic collection leading to toxic shock syndrome, such as pneumonia, empyema, or septic arthritis. Gynecological infections, such as chorioamnitis, such as postpartum infections, can also be there. However, they're less pertinent to our pediatric populations. Minor skin traumas and major skin traumas, such as recent surgeries and burns, can lead to this. Even some small viral infections, such as influenza and varicella, can also lead to toxic shock syndrome. Any kind of immunosuppression, such as morbid obesity, steroid abuse, HIV, or diabetes, or cardiac illnesses, can also predispose to a very catastrophic toxic shock syndrome. If we look at the risk factors that pertain to staphylococcal, that can be classified as menstrual associated or non-menstrual associated. As we talked about, menstrual associated is often because of these tampons, which are left in place for a very long time, and this gets colonized by our vaginal staph, and this can cause very high level of invasive infection, and it can be as common as 50% of the cases. Non-menstrual can be because of colonization in our nasal epithelium, or because of intrauterine devices or any other external devices. And this can lead to invasive staphylococcal infections where we can have a blood culture positivity. It can also be because of various other post-surgical infections, postpartum wound infections, and even after simple pneumonias. So why is it different from a usual presentation? How is the immunology different? So basically, the toxins that are released from staph or strep, these activate the T cells non-specifically. If we look at the left side diagram, that is the usual T cell presenting the antigen to our antigen presenting cells, which further activates approximately 0.01 to 0.1% of the T cell population, leading to a usual normal immunological response. However, in toxic shock syndrome, this process is bypassed with what is known as super antigens. So here, super antigens that are present on these endotoxins that are produced, they actually bypass the usual T cell and APC connection by an MHC, and this leads to a massive polyclonal T cell activation. Almost as high as 30% of our T cell population in the blood are activated, and it leads to an uncontrolled cytokine storm. It releases a huge flood of cytokines, NF kappa B, which further activates the interleukin cascade, TNF alphas, and this leads to a proper a systemic inflammatory response type of a syndrome. It can lead to a proper cytokine storm, causing a cascade of fever with rash, with shock and MOTS. So what are these super antigens? Super antigens are these exotoxins. These are produced either by Staph aureus, by TSST1, and group A beta hemolytical strep, which is known as our gas, or Pyogenes, endotoxin A, or both. So these super antigens are active in very, very low concentration, less than zero point 0.1 picograms, and these are barely detectable. However, there have been some researches where ex vivo specific, that is V beta TCR alterations, can help in diagnosis or confirm toxic shock syndrome. However, as per my knowledge, these are not rampantly available in India for testing. And usually, why are children more susceptible to toxic shock syndrome? Because of the usual absence of immunity against these, and lack of preventive antibodies make children less than 2 years far more susceptible. As we can see in this diagram, this plethora of cytokines that are released, they damage the endothelium, causing capillary leak. They damage the various end organs, causing further release of acute phase reactants, causing damage to liver, causing damage to kidneys, and leading to a proper inflammatory tissue injury, shock, and ischemia. So what are the clinical presentations? The clinical presentations can be divided into two aspects. One is the primary focus of our infection. Second is the systemic manifestation. So the primary focus of infection is what is going to help us clinch the diagnosis of what is exactly happening, or where is the infection coming from. And the systemic features are something which is going to prompt us an early ICU referral, or early active resuscitation. So primary focus of infection is essentially, in cases of staph, can be very silent. That is, that the colonized tampon or the colonized nasal packing can be a silent clinical presentation. We might not come to know what is the source of our infection in that poor child unless we do a thorough examination. It can be having small presentations, such as not absolutely silent but very minimal signs and symptoms, such as skin abscesses or surgical site infections. However, in streptococcal, the pain and the symptoms are going to be out of proportion on examination. So we will be able to find an evident focus of infection, such as a cellulitis or necrotizing fasciitis, and even a small abscess or a patch of cellulitis can be present. However, a florid or a very angry red looking kind of a strep is what is the characteristic presentation. Hence, strep toxic shock syndrome is much easier to pick up, much easier to identify. However, staph toxic shock syndrome is little silent at presentation in terms of its localization. Now, if you look at the systemic clinical presentation, there is going to be a rapid onset of hypotension. Now, this is the hallmark of toxic shock syndrome. This shock is going to be largely unresponsive to IV fluids, and there's going to be cyanosis in extremities, and it can lead to very fast tissue and ischemia and organ failure. So, poor fluid response of shock is one of the early clinical presentations of toxic shock syndrome. Fever is going to be very high, more than 102. The leukocytosis is actually going to be absent in the early part. However, there is going to be high amount of neutrophils. So the leukocytes, as they are recruited, they are going to be less in number in our testing. However, neutrophil predominance is what is going to help us clinch our diagnosis. There can be mucosal involvement in early phase. That is, there can be conjunctival insufflation. There can be hyperemia of mucosa, such as the vagina and oropharyngeal mucosa. In severe cases, early manifestations can also be ulceration in the mucous membranes, petechiae, vesicles, bullae. So this was the cohort of PJ Chandigarh, which evaluated 63 patients over a decade, where they found that the median age of kids who were presenting were barely 5 years. The duration of symptoms at the time of presentation were varying between 2 to 7 days. That is very early onset into the illness. Fever was present in 100% of the patients. Rash was present. So the characteristic rash, that is an erythematous skin burn type of rash was present in almost 95% of the kids, followed by some GI disturbance in 50% and respiratory distress in 50%. So GI disturbance in the form of diarrhea, vomiting can be present, and respiratory distress can be present in 50% of the kids. And hospitalization was required in almost all patients, and more than 80% of the patients required IV fluids, IV antibiotics, and 50% had oxygen requirement. Almost 40% of the patients had severe shock, and hardly few patients had an identifiable focus of infection. So if you can look at the focus of infection, skin and soft tissue infection was seen in 40% of the cases, but primary infection was detected only in 60% of the patients. Not all patients could have a primary focus of infection. So if we are able to find a primary focus of infection, we are lucky. But the systemic signs and the worsening shock and the worsening parameters of the patient and that sheer toxic look is what should prompt intensivists to actually go for aggressive management. So if you look at the organ system dysfunction, thrombocytopenia, transaminitis, and DIC and coagulopathy, these were predominant parameters that were deranged. Renal dysfunction, CNS involvement such as altered sensorium, confusion-like state, these were also very common. The desquamation that is characteristically described as a later presentation in toxic shock syndrome was hardly seen in 6% of the cases. So if we were to organize and divide bit staph and strep associated toxic shock syndrome, staph is essentially seen in children and adolescents, whereas strep is seen in very young kids as less than 2 years of age. Staph is going to have very high fever, whereas strep is going to have very severe pain at the site of infection. The focus of infection is going to be very prominent. Staph is going to present with an erythroderma type of a rash, and it can have later desquamation. However, strep is going to have higher likelihood of ARDS and respiratory dysfunction. It is going to have higher likelihood of renal impairment, coagulopathy, and liver derangement. However, staph is going to have predominant GI symptoms with vomiting, diarrhea, muscle aches, and some sort of mucositis. Respiratory distress is much less in staph. Mortality rates are also much less in staph. However, strep progresses to toxic shock syndrome within 48 hours. It is more commonly associated with toxic shock syndrome, and it has much higher mortality rates, as high as 20 to 50%. So when we find such a sick kid, what other differentials come to our mind? The most common and the most the topmost differential that will come to our mind will be a gram-negative septicemia. So a kid who's having high-grade fever, who is coming in shock, gram-negative septicemia will be more common. If we are having a prominent rash, desquamation, conjunctival insufflation, or even red spots in our tongue, Kawasaki and scarlet fever also come into the picture. Dress and other tropical fevers such as dengue, like in the current season, dengue and malaria could also present in the similar way. And at the time of COVID MISC was also very similarly described. So amongst all these differential diagnoses, unless we are able to find a culture positivity, we'll never be able to figure out whether this is a simple gram-negative septicemia or a tropical fever, or whether we're dealing with a toxic shock syndrome. Hence, our management has to be broadly outlined. So how will we try to make the diagnosis? So the diagnosis is going to be a combination of our clinical parameters and laboratory evidence. So first and foremost, we must try to gather cultures from the potential infection source, the skin or the throat or the nose, additional to blood and urine cultures. As the TLCs might be normal and neutrophils would be high, there might be a left shift, which can help us move to our diagnosis. Severe thrombocytopenia is often seen in later stages and often an ominous sign. And kids might end up developing full-blown DIC, and much later in the course, this can lead to catastrophic bleeding. Creat kinase, because of myalgias and arthralgias, can be very high. If you look at the yield of blood cultures, which is one of the most common and the best methods of diagnosis, in staph, the blood culture yields are very low. However, in strep, the blood culture yields are very high. And strep being more common, it will be much easier to diagnose. So this is the CDC criteria for diagnosis of toxic shock syndrome. So this is divided into clinical criteria, laboratory criteria, and a case classification. So probable case is going to be if we are able to meet the laboratory criteria and 4 to 5 clinical criteria. And a confirmed case is going to be if we are able to have the laboratory criteria and all of the 5 clinical criteria. So, fever, rash, desquamation 1 to 2 weeks after the onset of rash, hypotension. These are the uh, predominant clinical criteria in addition to multi-system organ involvement. So, 3 or more of the organ system involvement is what is the final clinical criteria. What are the organs involvement like GI symptoms such as vomiting and diarrhea. Muscular symptoms like severe myalgia, pain with elevated CKs, mucosal involvement and hyperemia, renal involvement in which it can present as pyuria or AKI, hepatic involvements either because of ischemic hepatitis or because of simple transaminitis, hematological involvement in the form of thrombocytopenia, and some amount of disorientation and confusion in the absence of fever. So these are the main clinical criteria. Although these are very non-specific and although these have been debated at various researches and reviews, this is essentially the only clinical criteria with which we can come to a diagnosis of toxic shock syndrome or at least a possibility of toxic shock syndrome. So coming to management, the management comprises of multiple things. First and foremost is timely resuscitation. So as we already figured that because of the severe cytokine storm, there is going to be endothelial damage. So this shock is barely going to be responsive to fluids. Hence, we have to be very conservative in giving fluid resuscitation. So almost all patients will require immediate vasopressor support and some conservative to moderate fluid resuscitation strategies. This is very important. If the patients are requiring high doses of vasopressors, so early use of stress dose of steroids is indicated, such as hydrocortisone of 50 milligrams QID. In cases of refractory shock and underlying immune suppression, also stress doses of steroids can be very beneficial. Appropriate use of antibiotics, which I shall be discussing, targeted and adjunctive therapy such as IVIG and antitoxin therapy, which I shall be discussing, and source control. Source control is always our golden thumb rule in cases of any pyogenic infections, whether toxin producing or non-toxic producing, without which simple IV antibiotics are really not going to cause a beneficial effect. And supportive care within our PICUs is of utmost importance. So if you look at the evidence behind usage of IVIG, there have been multiple observational studies. There has been only one randomized controlled trial which I could find in the recent times, and there has been one systematic review meta-analysis which included the largest 5 studies. This claims to show that there is some suggestive survival benefit with the use of IVIG in patients who are already taking clindamycin for strep toxic shock syndrome. So IVIG did not have much benefit in terms of delaying the shock, but yes, there has been some survival benefit. So IVIG with a dose of 1 gram per kg on day 1, if there is a response followed by 0.5 grams per kg for 2 to 3 doses. However, if the response is not visible in the next day, then it can be raised to 2 grams per kg per day. There is less evidence to support the use of IVIG in staph toxic shock syndrome, and it is less responsive to IVIG. But however, as it might be difficult to differentiate between the two, it is always advisable that if the shock is worsening, IVIG is promptly initiated. What about the antibiotics? So till the time we are not able to clinch the diagnosis of a toxic shock syndrome and our primary differential continues to be gram-negative septicemia, our empirical choice of antibiotics must include a broad range. That is, it must include a cover for MRSA and a effective beta-lactam depending on our source of infection. Additional to an antitoxin. So what is an antitoxin? Antitoxin is basically to suppress the toxin secretion and the preformed toxin. So what is IVIG going to do? IVIG is going to neutralize the antibodies and the cascade of cytokine storm, and antitoxin is going to neutralize the preformed toxins. However, the ongoing production of toxin is going to be stopped by the antibiotic per se. Right. So what are the antitoxins? High dose of linezolid and high dose of clindamycin have been shown to have some evidence to prove as an antitoxin. So clindamycin has much more robust data in terms of clinical and animal data to be used in severe strep infections at a higher dose, as high as 900 milligrams TDS rather than the usual 600 milligrams TDS. Linezolid is at a higher advantage as compared to clindamycin, as it covers MRSA per se itself also. However, the data is not as robust as clindamycin, and linezolid with a dose of 600 milligram BD can cover preformed toxin of both staph and strep. So there have been some arguments and there have been some hypotheses of using both together. So the combination of clindamycin and linezolid, it has not been found to be harmful, but there have not been any RCTs to prove evidence or enough to form a recommendation. Additionally, beta-lactams are also combined with this toxin suppressive effect of antibiotic, and it can be used in strep infections. So beta-lactams such as third generation cephalosporins, BLB-like combinations, and even carbapenems such as meropenem can be used. Now, when should we discontinue this antitoxin? Antitoxins, clindamycin or linezolid, have to be discontinued 1 to 2 days only after the resolution of multi-organ failure, not before that. And yet again, source control and aggressive drainage and debridement of the tissue is most important to reduce the production of these super antigens and the preformed toxins. That will be all from my side. I hope I have summarized the recent evidence and advances in the management and clinching the diagnosis of toxic shock syndrome. Thank you so much. I would request the moderators to enlighten about their experience.
Yeah, Dr. Anivita, you can stop your slide sharing. Well, thank you for the very to the point focus review of the topic. If you go through the presentation, you have not left anything to discuss. However, I have a couple of questions for you. You rightly talked about incidence, then about pathophysiology. So we'll go one by one. With regard to pathophysiology, we understand it is toxin mediated. And then we have B cell and humoral. And primarily it looks like superantigen. So, and probably it falls in the context of hyperinflammatory syndrome. So you have pro-inflammatory cascade, you have anti-inflammatory cascade. So combining all together, what do you feel? What is the crux of pathophysiology with regard to toxic shock syndrome? One point which we could make out is superantigens.
Right, sir.
So what do you? Yeah.
It's only pro-inflammatory.
Sir.
It's essentially pro-inflammatory cytokines which are
pro-inflammatory.
Exactly, sir.
I did not get what sir said.
I said it is only pro-inflammatory.
Yeah. So
it's like a nuclear fission. It just goes on, multiplies. Difficult to stop.
Sir, use the perfect word, nuclear fission. It's almost like an atom bomb bursting in the body.
Yeah.
And it's absolutely uncontrollable.
And primarily it is toxin mediated, right?
Right, sir.
So that's number one. Now, well done. So next is risk factor. You talked about very well. Clinical features, fine enough. Uh, uh, well, you talked very good study about the PGI Chandigarh. Can you elaborate about a bit about the outcome part of the study? Out of 63 patients, what was the outcome? Have you gone through that?
Yes, sir. So in that study, sir, basically the outcome was approximately there were about 30 to 10% mortality. But essentially, what they were trying to focus on was that the CDC criteria was very vague. Not all patients were essentially only toxic shock syndrome. Later on, they figured that many patients could have been an overlap between Kawasaki, could have been an overlap between scarlet shock syndrome. So, hence, they also concluded that their CDC criteria, which they used for recruitment of the patients, could have been having very blurred outlines. So that is what makes us realize that we are also underdiagnosing and underreporting toxic shock syndrome. So the mortalities of aggressively forming toxic shock syndromes are definitely going to be high. But as per literature, staph doesn't cause that high mortality. So we might be underreporting that. So if we are looking at a study essentially in PICUs, then we are biased towards higher mortality. But that might not be the real world data.
So that's about the outcome in the study. Diagnosis, you are well covered. With regard to management, you rightly talked about primary registration, organ stabilization, targeted therapy, and source control. I have a couple of questions with regard to immune modulation. So what is the role of immune modulation in toxic shock syndrome apart from steroid? Well, you talked about steroid in 50 milligrams 6 hourly. That's an adult. Pediatric, our dose is 50 to 100 milligram per meter square hydrocortisone 6 hourly, or we can use 0.5 milligram per kg 6 hourly. So this is a dose of steroid in pediatric, stress dose of steroid.
Right.
That's number one. So coming back to my questions, what is the role of immune modulation in toxic shock syndrome?
So, yeah. So
Yes,
please go.
sir. Yes, sir.
No, I'm just going right. I would have been asking the same thing, Dr. Anvita.
Yes, sir.
Do you think how do you in a lot of children of between 6 months, let's say 3 months to 1 year, who have a common protein allergy, they develop something called F5s, which is a food protein induced enterocolitis, which they suddenly come in severe shock with diarrhea, vomiting, and shock, which is, but it's non-IgM. Similarly, my question to you is, what kind of reaction you put this kind of TSS? It's neither type 1 reaction, neither type 2 reaction, not type 3, not type 4. So which category will it fit into? Because it is humongous, the way the super antigen causing the cytokine storm, which we read first time during COVID time. Now
Exactly, sir. Right, sir.
About this now,
Right,
it's clearer. So I doubt whether any immune moderation can work in this such a short. Immune moderation works usually in type 3, type 4 kind of reactions. I have never used. I have no idea about it. You can enlighten
So
us.
as you rightly pointed out, sir, like we have already mentioned all these, like we've read toxic cytokine storms in the times of COVID era. So something similar can be applied in toxic shock syndrome. So things like immune modulators such as tocilizumab, immune modulators which are blocking our IL-6, these can be the ones which can be actually considered using, and even things which we use in severe sepsis in our ICU settings, such as cytosorbs, which are essentially used to absorb all these toxins and the inflammatory cytokines mediators from the body. These can be tried, but although I could not find any robust clinical evidence as of now which has proven benefit, but I'm sure in our ICU settings you must be having your experience where when push comes to shove, We try everything. Steroids is something that we start upfront, after which we start IVIG, and if the kid or the adult is still crashing, we are left with no other option but to go for immunomodulators such as tocilizumab, or an NF-kappa beta blocker such as uh, right, sir.
So you have biologics and you have plasma exchange. So have we been able to have any literature with regard to use of this in toxic shock syndrome?
So more than plasma exchange, sir, I found evidence towards IVIG. And using plasma exchange is going to actually be counterproductive. So either we'll have to use either of the two strategies. We can't be using both. So in the older studies, I did find a few studies on plasma exchange, but amongst the recent evidence, they were more driven towards use of IVIG.
Yeah, that means the Plex is not the first line of therapy. It's
Right,
only
sir.
indicated where you have refractory toxic shock syndrome, or you have severe cases with multiple system syndrome. There, if your first line therapy like steroids or IVIG is not working, then one may consider again when you are pushed against the wall, right?
Yes, sir. And that is also very old evidence, sir. None of the recent articles or studies are supporting Plex at all.
Yeah, yeah. Okay, couple of more questions if you permit.
Sure, sir.
What about the recurrence rate of TSS?
Right, sir. So in literature, there have been reported a few cases of recurrence, especially in immunosuppressed individuals and patients who are having recurrent fasciitis and cellulitis. And they are often with lesser mortality, probably because of some preformed antibodies. But I couldn't find much data from India. So I would actually want up, some personal first-hand experience from your side, that if you've had such recurrent TSS, and how have you managed it in your ICU setting, sir?
Well, to be honest, we don't have much of cases of TSS. As you rightly said, it's very less. However, we don't have any recurrence of TSS with us. Whatever, like I have almost 20 years of PICU, I have not seen any recurrence. And with regard to literature, also any long-term effects of TSS?
So long-term effects are something like what we saw in COVID, sir. So there can be end organ damage, there can be all the ischemic changes that can be leading to some residual damage, mostly residual cerebral defects, residual renal dysfunction, residual liver dysfunction is what I
So organ-specific
right, sir.
effects.
End organ
That's
damage.
fine. And the last question from my end is, how can we prevent, including the role of vaccines in TSS?
So, sir, pneumococcal vaccine is the only vaccine that is there to prevent. However, one good strategy is prevention of recurrence by nasal carriage of staph. So, nasal decontamination in patients who have nasal carriage, and early detection and diagnosis. These are the only two preventive strategies. But vaccination has not really found to be very preventive of uh, strep gas forming toxic shock syndrome, but yes, that can be our fair shot.
Well, to conclude from my end, I feel that it's a very important entity, toxic shock syndrome. Identifying at the first contact. I mean, it's not that the intensivist identify. The first contact, whether it is a primary care pediatrician or otherwise, they must be sensitized to identify this TSS, and initial management followed by referral to appropriate center. It's very important because in the TSS,
time is the time.
The TSS time is the factor. Time is the factor. And if you, and other way around also, if you manage properly, they revert back very fast. And it's very gratifying to see them back fast, because they don't have any comorbidity. So they revert back very fast. So time is the key. And I must, from my end, I must congratulate Dr. Anivita for such a comprehensive, to the point, and within time limit presentation. Thank you from my end. Over to you, sir.
Thank you so much.
I think you have done everything. Nothing else. I just thought if you could tell us differentiate between DRESS syndrome and the TSS. There's a lot of confusion between that.
Right, sir. So I think eosinophilia, the history, and also the type of evolution of the rash, sir. These are the three differences. The starting of the rash in the form of erythroderma is going to be overlapping between the two, but the lack of blistering in toxic shock syndrome essentially, and that the marbling type of effect that we see in DRESS is not going to be present. However, if we see, sir, the treatment is essentially the same for both. There's going to be steroids and IVIG. So eosinophilia, which is hardly present in around 50 to 70% of cases in DRESS, is going to be our clinching diagnosis. IgE levels is going to be the differentiating point, and a clinical history, I believe, sir. If we talk about blood culture positivity, that is, the yield of blood cultures is very low in staph. In STEP also hardly 50 to 60%. So if at all we are lucky and we have a blood culture positivity, we wouldn't know whether it is secondary bacterial infection or it is the primary toxic shock syndrome. But I believe in my clinical experience, DRESS evolves a little more slowly.
Yeah.
And toxic shock syndrome is not going to give us time at all. DRESS is going to take about a few days, and this will take a few hours.
Yeah.
Developing.
Yeah, I mean, you have a history of exposure to certain drug, and
Right.
the shock is told to be more catastrophic and very fast in the toxic shock syndrome compared to DRESS. The shock part.
Thank you. Very nice presented, Dr. It is such a lucid, brief, and to the point.
Thank
And
you so
Dr. Sheikh has really asked everything what he would wanted to ask.
Thank you. So over to IAP Delhi and ICH Gangaram. So can we conclude, sir?
I think what else is there?
Yeah, thank you. Thank you, Dr. Anvita, for such a lucid, to the point, and you covered almost everything. I went through, it was almost, and a couple of things are extremely good with regard to your CDC criteria and other criteria. And that's study from PGI, which was done by our own friend Suresh Kumar Angurana. He's a young pediatrician doing extremely well with Arun Bansal and Jayashri madam. So good study. Over to all. Thank you. Should we wind up?
Yeah, thank you.
Okay. Thank you, sir. We'll